invitation within a short period of time. So ma'am is a professor of pediatrics and as well head pediatric pulmonology from a prestigious medical institute, that is PGMR, Postgraduate Institute of Medical Education and Research, Chandigarh. And ma'am completed her MBBS from Himachal Pradesh University, Shimla, and she received fellowship pediatric pulmonology from University of Pittsburgh, Pennsylvania, USA. And when you see our research, ma'am's research area, it's a combination of both pediatrics and pulmonology. So she and her group done a wonderful work in related areas of pediatrics and pulmonology, especially like BCG vaccination, tuberculosis, cystic fibrosis, and many other areas under the pediatrics and pulmonology. Coming to the expertise in the area of systematic review and meta-analysis, I used to follow the papers by Dr. Meenu Singh and colleagues. So they have already written various papers on systematic review and meta-analysis, and I'm glad to see even they have various Cochrane systematic reviews as well on the names of Dr. Meenu Singh as well as other colleagues. So I'm sure that the expertise from the Dr. Meenu Singh is going to be very useful for us as an initial session for this 2 days national online workshop. And with this, I request Dr. Meenu Singh to share the presentation and content. Ma'am, can I have your screen, please?
Yeah, I've just clicked on share screen.
Yes, ma'am.
Is it working?
No, it's not. Dr. Krishna, it is not coming. Just can you please?
Yes, sir. We are checking, sir. We are checking, sir. We are checking.
Actually,
Ma'am, can you click on the share screen like yesterday we did?
yes, I am there, but wait a minute. It's actually not showing my showing your screen. So okay, I think share desktop, is that?
Yes, ma'am. Share your desktop.
Is it coming now? Is it sharing your desktop and not mine? Are we there?
I think Krishna, you take the PPT from Dr. Singhu and then you can run the show from your side, at least.
Yes, sir. We will try that option, sir. If it is not working.
No, let us not waste the time. You know that you have taken her PPT now.
No, sir. It is not with me, ma'am. Can we try just once, ma'am? One more time. I just closed my
Actually,
screen.
I want to full screen. Actually, it is showing your screen and.
Yes, ma'am. I'm getting now. I'm getting now.
You getting? Or
I'm getting now. Yeah.
Okay.
Put it in slideshow mode. Put it in slideshow.
Yes, sir.
Yeah, I'll do that.
Wonderful. It's fine.
Is it coming now in slideshow?
Yes, ma'am. It is coming. I'm just sharing it.
So I will just start with my presentation. Basically, the title which has been given to me is using systematic reviews for healthcare decision making or making decisions in healthcare. So as far as healthcare is concerned, there are two kinds of settings in which we can think of using evidence, and systematic reviews, as we know, are at the helm of evidence in medicine, and like randomized control trials, systematic reviews head the hierarchy of evidence. So obviously they are extremely important in decision making. So decisions in healthcare are made at the level of patients, when they want to choose a particular therapy, they are also made at the level of doctors when they want to apply a particular technique or a therapy to their patients. But they are also used at the level of policymakers when they want to use a particular evidence to start a scheme or a policy or a program to benefit patients as far as healthcare is considered. For example, we can take an example of the COVID-19 epidemic, which is going on right now, and people are resorting to all kind of evidence to take on therapies to use in this particular condition. And you might have seen that we are seeing a large number of systematic reviews which are appearing in the literature, but they are actually not based on randomized control trials which have already been done, because in this particular epidemic there are hardly any RCTs which are there. There are very few RCTs, for example, say in hydroxychloroquine or azithromycin, and people are trying to make decisions based on that evidence whichever is available. So in this kind of epidemic study, people have actually gone into also conducting what are known as rapid reviews, which are actually rapid systematic reviews, in which you are actually not adhering to a lot of quality standards which otherwise are supposed to be practiced in systematic reviews. So my talk today will be based more on how a health policy maker makes decisions based on systematic reviews. So that's my conflict of interest. Don't have conflict of interest. This is our ICMR Advanced Center for Evidence-Based Child Health, in which we, as you mentioned, Krishna, we have a number of our researchers which are actually doing quite well, and they are publishing systematic reviews as well as Cochrane systematic reviews, which are considered to be quality reviews. So I would like to give you a little brief about policymakers and systematic reviewers. And Institute of Education Epicenter in University College of London is something where a lot of systematic reviews are done, and they are applied to policy. And as you know, in UK you have something known as NICE, which is National Institute of Clinical Excellence, which uses systematic reviews in deciding which therapies they would like to implement in their National Health Service. So for definition of systematic review is a review of research literature using methods that are systematic, explicit, and accountable. And it is this very reason, because they are systematic, they can feed the policy. Because many times the traditional reviews which are there, which are very much biased, and they might even lead to adoption of wrong policies or biased concepts, and that may lead to problems. Hence, systematic reviews which are systematic, which have a definite methodology underlying them, which are transparent, explicit, which describe each and everything, why they included a particular study, why they excluded a particular study, why a particular study has less methodological quality, why the other one doesn't have has more methodological quality. So all these things have been described in methods. Hence, whenever we are using them in guidelines or we are using them in policy, they consider to have much more importance, and they become extremely important to feed the policy. So systematic reviews can be considered relevant to policy and of course policymakers when they present findings clearly for policy audiences, that is to illuminate policy problems, then to challenge or develop policy assumptions, offer evidence about the impact of implementation of policy options, and take into account diversity of people and contexts. To give you an example, at the moment we are having a policy known as a very big program, our national program on health, the Ayushman Bharat program, and PM's Jan Arogya Yojana, in which we are implementing a number of findings. And these policies are, but otherwise, based on some values as to how much is the requirement of a particular policy for that particular implementation. For example, the baseline for this was National Rural Health Mission or the National Health Mission, which actually gave us ideas about the requirements of populations and what prioritization would need to be done for using particular intervention in a given situation. And we know that in our country, the mostly the problems are economical. The problems are also about access. The problems are also about reaching the healthcare facilities. So all these were being taken care of in these particular health problems. And as we can see, even NITI Aayog, the currently organization which makes all the decisions, would also rely on evidence which comes from different fields. So systematic reviews may figure the findings of studies on issue to construct a theory about health systems. More often, they aggregate the findings of similar studies to test a theory or even mix these approaches within frameworks that make sense to stakeholders to present what can be learned from available literature. So it is not just reading literature or putting everything together. It is also interpreting these findings and actually trying to see what makes sense for a disease condition. And as I said, there are several users of systematic reviews. There are doctors, there are patients, there are policymakers. So all these people would look at these systematic reviews with their own interest. And hence, a systematic review which has been done, it should give all the requirements for, it should meet the requirements of all the people who are actually going to use it. For example, for a patient, the most important thing which would matter is whether he is going to become all right or not using an intervention. So efficacy of a particular medication would be of utmost importance to the patient. Similarly, the safety of the intervention is also of importance to the patients. And the same applies to the medical professionals also. That means the doctors and the nurses. But the doctors also have a wider vision, a wider view of what to use in a particular patient. For example, they may think that there are certain risk factors or certain derivatives in the patient's characteristics, which may make that particular intervention less effective. In that case, the doctor has the freedom to choose and apply a particular evidence to that particular disease condition. But when we come to a wider canvas, when we are looking at adoption of a particular intervention for a larger interest of the population, that concerns the policymakers, and that is how they look at all the pros and cons. And what they are really worried about is also the economic analysis. We know that systematic reviews sometimes would lead to what is known as health risk-benefit ratio, and that would tell us as to what are the risks and what are the benefits. And some of these would also include economic analysis. That means how much money would need to be spent to save a patient's life or to avert a particular condition. So these things also become important when we are doing systematic reviews and when we are trying to apply them to policy. Okay, now these are the typical steps for conducting a systematic review. And all of you who would be undergoing this workshop, you will be asked to frame a research question first, because systematic review starts with a question. And in case of medical literature, you need to have a research question, the answer to which is not very clear. And you would want to answer that question at the end of a systematic review. It is just like taking up a research project. So the review initiation would tell us about the identification of the evidence gap. That means that is the step 0. When we accept uncertainty, when we say that we don't know the answer to this particular question, we don't really know whether remdesivir would work in COVID or not. That is one of the questions which we have taken. Then we usually try to split that particular research question into a conceptual framework, and then we make it into greater details, what is known as PICO, and what includes population, intervention, comparators, outcomes. And that review question would then be subsequently modified based on what is the population. For example, here, say the population is that of patients who are suffering from COVID-19 infection. Intervention here is using remdesivir. Comparator is the other standard therapies without remdesivir. And outcome would be, of course, how quickly the patient recovers, or whether we have averted a death if the patient was seriously sick, or how much time the patient has taken to become absolutely all right. So these are some of the outcomes which one would consider in that particular question. After this, after we have this PICO, so-called, this is an acronym which you will be made familiar with, I think, in the subsequent sessions, where you would then decide that this is the population, and you would then go looking for studies. You would see how much is the evidence which is available there, and then you identify the studies of interest. And studies of interest is something which you have in your inclusion criteria, which could be randomized controlled trials, and then you go searching for studies to the libraries, and these libraries are not just in the buildings, they are also on the databases, which would be say PubMed. You look for Embase, you look for Cochrane Library, you look for other databases on update software, or we look on COVID. So there are a huge number of databases which you need to look at when you are trying to find the studies which are of interest to you, which are actually going to get included in that particular systematic review. So after you have studies at hand and you have a team at hand, that means 3 or 4 systematic reviewers who join together to have minimum amount of bias, because if it's just one person, it's likely to get biased. Then you describe the studies in the term of interest to stakeholders. That means you describe study characteristics, what we do in using the conceptual framework of PICO, in which we usually make a table in which we try to describe each and every study based on all these components. But here, when we are using it for the policy makers, we also describe studies in terms of interest to the stakeholders. So if the stakeholder is a doctor or a patient, then we are more focused on clinical outcomes. But if the stakeholders is a public health person, we are more focused on public health outcomes or the epidemiological characteristics. So these are some of the variations which take place when you are describing studies or when you are extracting data from the given studies. After this, something which is very important is that of quality assessment. And quality assessment is extremely important to all the stakeholders, to the reviewers, as well as to the people who are going to use them. And hence, we appraise the studies in terms of interest of the stakeholders when we are thinking in terms of policy. But we are otherwise, quality assessment of the studies is to obviate the occurrence of risk of bias, which is usually there in the studies. Like we have risk of bias tool, which is used for quality assessment of the studies. For example, in the same question of remdesivir for COVID, you may have to do quality assessment of randomized controlled trials if they are there by using your risk of bias tool. Now, after you have made quality assessment, you would extract data from the studies and you would like to enter that data into some statistical program because you want to synthesize the results. And that is what is known as meta-analysis for the systematic reviewer and also for all the readers of the systematic reviewers, who must also know how to interpret a meta-analysis, how to read a forest plot, and how to apply the results which have been seen in that particular systematic review to their clinical condition. Because it's extremely important that after discussing the meaning of emerging studies, we should be able to use reviews, and then after we that means after we have the findings, we should be sharing these findings through networks and using findings for different kind of debates and discussions. So a good systematic review questions are important for policy debates and decisions, and these are as judged by people making those decisions. They have not been answered. If the questions have not been answered by systematic reviews before, then we try to do systematic review on them, and that is apparent from the maps of systematic reviews. We have consensus over the definition of the key concept, that is, which is explored in the background literature and discussion between the stakeholders, then you find sufficient studies to provide useful answers, and that is judged by maps of primary studies and the initial searches by the review teams. And we must avoid overwhelming numbers to allow a manageable review, because that can otherwise lead to confusion in the mind of people. So we must have a strategy in which we try to limit the research question to a particular clinical problem, and then take the studies which are of a given study design, for example, only randomized controlled trials or only cohort studies, and then try to do a systematic review. Now, this is about the evidence for multiple audiences. On one side, you have key concepts which are clear and widely agreed, and on the other side, we have evidence for multiple audiences. Now, in the first model, that is model 1, these are common decisions and they are clearly defined. And the library of reviews would be here standardized concepts and methods, which is keeping us up to date, which have open access products. So that means you go to databases which already give you ready-made reviews, and that is something which is known as, say, we go to Cochrane reviews, which will be quality reviews. Then there are Campbell reviews, which are there from the Campbell collaboration. In the second model, we have specific decisions, and they are clearly defined. And here we have to have it locally appropriate, because locally applicable reviews are extremely important. Then you call the review teams and you focus on particular context. For example, these days we have a health technology assessment board, which is actually trying to adopt strategies which can be used for particular healthcare interventions. So they have to be used in India, and you may not find a systematic review on a particular healthcare intervention. So here, this body asks systematic reviewers in India or otherwise to do some systematic reviews, and sometimes they use rapid methods. For example, in the setting of COVID, we had to apply, some of these strategies in an emergency situation. So we have to use rapid methods, and that then gets incorporated into the national policies. Then you have another model in which you have common decisions, but they lack clarity. That means the question itself is not very clear, and we don't really know whether to take up that question for doing a systematic review, and whether to take up that intervention in policy or not. So here the broad commitment is taken by a widespread consultation. The time is given for debate. The newly agreed concepts and methods are applied, and open access products are given. For example, WHO guidelines. We had WHO guidelines even for COVID management, and a whole lot of consultation was done on that from different countries. Similarly, these days we have National Digital Health Mission, which has just started with the Prime Minister's announcement on the Independence Day speech. And right now there is a lot of consultation which is being done on that as to how to implement that. So these are some of the things in which still there is not much of clarity, but you may need to review these topics. Then there are specific decisions also lacking clarity. For example, some of the things which are not entirely known, for example, say for National Digital Health Mission. So here you need knowledge brokering. Knowledge brokering means you need systematic reviews, people who will interpret knowledge for you. Then reviews which are focused to that specific question, using or reanalyzing what are the existing systematic reviews. Here again, some rapid methods can be used. So you can see that whenever we have specific decisions to be made, sometimes we have to use rapid methods. So these systematic review models address policymakers' requirement for use of evidence, and relevance is achieved by interaction between policymakers and researchers during the review process. Ready access is through policy available libraries or systematic reviews or close collaboration with research teams, and timeliness is addressed by publicly available libraries, knowledge brokers, and rapid review methods. So let us now just address one problem. We know that under 5 mortality in India is significantly high, and pneumonia is one of the leading causes. Streptococcus pneumoniae is one of the common organisms. So I will just run through some of these slides because not much time is left for me now. So that I'm just giving you an example how a particular problem can be addressed and the results applied to framing of policy of our healthcare interventions. So pneumococcal disease is there. There is a magnitude of disease and prevalent serotypes. That is one of the questions which need to be known. And the burden of invasive pneumococcal disease was something which was required to be done in South Asian countries. And there were about 22 studies of about 2,500 children, and about 663 children were confirmed with invasive pneumococcal disease. And we studied from 1 month to 12 years. This review was conducted by our group, by Dr. Nishant Jaiswal and all other people. And this is what showed us the burden of the disease. And this forest plot actually gives you the prevalence of pneumococcal disease as coming out of different studies. So this also gave us about pneumonia. But another question which was important was that of serotype distribution in India, because ultimately the question is that of vaccination, as to what vaccine should be used for prevention of pneumococcal disease. So again, a systematic search was done, and pneumococcal serotype distribution amongst Indian children was nasopharyngeal carriage of organisms in children with severe pneumonia, and then whatever had come from culture of secretions of these patients was taken as a data. And ultimately, percentage of IPD in children due to vaccine serotypes was also seen, and that led to what should be the vaccine serotypes which should be used, and again it also told us about what antibiotics should be used in this. So the question which needed to be addressed was that, is the evidence of pneumococcal disease burden in India sufficient to consider feasibility of immunization as an effective control strategy? So we found that this data was sufficient to conclude that there is significant disease burden in India, and the studies on nasopharyngeal aspirates have also shown similar results. However, there were some concerns that other serotypes which may become more prevalent, which are not included in the vaccination, may become more common after that, which some of the things may actually become more likely. So this particular problem actually was taken up by the NTAGI, which is the national body deciding about, it's a technical group which decides about adoption of pneumococcal vaccines, and then that vaccination was taken. So this is a kind of question which has been addressed in systematic reviews, and a national policy has been framed on that. So with that, I think I will give a stop to my talk, and I'm open to questions. It's about 9:56, so I can take up some questions.
Thank you, ma'am. Thank you for the content. I think it's very much elaborated, and I'm sure all the audience got at least how the systematic reviews are going to be useful for us on day-to-day basis for taking any decision. Ma'am, as such, there are no questions at present from the participants. Maybe at least, ma'am, you can just express your expertise, like as a treating physician in pulmonology and pediatrics, and how exactly the systematic reviews are going to be useful for us for taking any decision on day-to-day basis treatment.
Yeah. So, in the same question of pneumococcal disease, we know that pneumonia is a very common condition which is faced by pediatricians, which are, and also they come to pediatric pulmonologists sometimes. And we had an example of, say, which antibiotic to use for pneumococcus. So it would depend upon antibiotic resistance patterns which are there. And as we know that these policies keep changing based on the antibiotic surveillance. And earlier we found that penicillin was effective. We found that, cotrimoxazole was effective. And people were actually, WHO was also recommending cotrimoxazole in the kits which are given to the community health workers for treating pneumonias. But with change in information, when we found that most of these strains had become resistant to some of these medications, then we have to resort to things like ampicillin, amoxicillin, or acid. So these things are also guided by systematic review. So if you keep using things which are not supported by evidence, you may not be able to give the best treatment to patients. Similarly, we did another systematic review. We did some randomized control trial on use of streptokinase in empymas, empymas which are accumulation of pus in the pleural space, and we found that patients who were given streptokinase intrapleurally, these are fibrinolytic agents, they fared better later on. So there were few studies on that, and we find that when the evidence is collated, we still don't have clarity as to whether we should be using these agents or not. So this is still a research question then. That means you need to have a variation in the study intervention. You may use a different kind of fibrinolytic agent. You may use a different schedule, a different dose, and your baseline characteristics of patients may vary. So these are the things which, when you are applying evidence to clinical practice, that becomes extremely important. So you should know how to interpret the results and to see whether these results are clear enough to apply it to the patients, or it is still open to research. So that is something which we need to
sure, ma'am. Thank you. Ma'am, one more last question, especially during this COVID-19. So we can see regularly there are many studies which are coming up, especially maybe the randomized control trials. So is it okay, maybe we can take some information for healthcare practice from randomized control trial which are coming up daily, or maybe we can wait for a systematic review or better level of evidence till we can take a decision?
I think a good quality randomized control trial, if it is a good quality, means if it is a double-blind randomized control trial with adequate sample size, with all methodological issues addressed, would be able to answer the questions which would otherwise come in systematic reviews. But as you know, if they are multicentric, that means they have generalizability. That would be important, because sometimes some treatments work in some clinical settings or in some populations, and they may not work in other populations. So that is one consideration which can be seen, that systematic reviews would still be applicable. That's why people are going for rapid reviews for COVID-19, and they are not taking as much time, otherwise it takes 3 to 6 months to do a systematic review. So rapid reviews, the methodology is a little bit compromised and it's kind of accelerated, and people are actually using some artificial intelligence also in that. And then you can come out with the conclusions faster and you can apply these results to your patients. But I think evidence from RCTs, as you would be shown in your talk on levels of evidence, RCT is a good RCT is as good as a systematic review. So you can take evidence for that and maybe try to see how much benefit it will have, what are the numbers needed to treat, how much benefit it would really have in your population.
Sure, ma'am. Thank you so much, ma'am. Thank you for your time. I'm sure already the participants got benefited with your talk. And I know your busy schedule. Thank you for joining with us in the early morning.
I have something lined up. Actually, I have something else, but I'll return later on to your.
Sure, ma'am. Yeah. Sure. Thank you so much. Thank you.
However, I'll keep my thing on.